Thank you for joining me for this program, Diagnostic Uptake Tuberculosis in Children. I am Dr. Ana Alvarez, and I am an associate professor in the Division of Pediatric Infectious Diseases and Immunology at the University of Florida College of Medicine in Jacksonville. I have worked with pediatric TB for the last 25 years. I don't want to say my age, but that's how long I've worked with pediatric TB, and this has become one of my passions. So I am glad that I was invited to share with you some of the things that I've learned in pediatric TB. I am a consultant for Oxford Immunotech, but I have no other disclosures. My goals are that at the end of this session, you will be able to define latent tuberculosis infection. We use LTBI for short. List the tests that are currently available to diagnose TB in children and discuss their advantages and disadvantages. And discuss the appropriate workup for pediatric patients with suspected TB. I usually like to start my presentations with cases because I feel that bring it to your reality as clinicians. So I am going to go through a series of cases that we'll discuss at the end. Case number 1 is a 2-year-old Hispanic female who moved from Guatemala 6 months ago, and she received BCG vaccine at birth. And now she is brought to your clinic by her family for evaluation because her grandmother in Guatemala was recently diagnosed with TB. She has no symptoms and her exam is normal. So briefly, she's a 2-year-old non-US born female with no symptoms and normal exam, but with a potential exposure to TB. So the question is, what will you do next? Case 2 is a 12-year-old Asian male who moved to the US from China 2 years ago. He received BCG vaccination in China as an infant. Upon arrival to the US, a TST was placed and it was read as 13 millimeters of induration. So a chest X-ray was obtained and it was read as normal. He has no symptoms of TB disease, and in further questioning, there is no known TB contacts. He was offered treatment for latent tuberculosis infection, but the family refused because they believe that the TSG result is due to the BCG vaccination. So he's a 12-year-old non-US born male with no significant exposure to TB, no symptoms, normal exam, but with a positive TST. So the question is, what do you do next? Our third case is a 17-year-old Caucasian female who was diagnosed with Crohn's disease last year, and she was treated with corticosteroids but was not responding. So her GI doctor is considering starting her on Humira, which is a TNF-alpha antagonist. She has no symptoms of TB disease, no known TB contacts. However, the summer before her diagnosis, she volunteered in a food bank for the homeless in her city. So she's a 17-year-old female with inflammatory bowel disease, status post courses of corticosteroids, no TB symptoms, no known exposure to TB, or a potential risk factor. Again, what will you do next? So now we're going to go through the presentation. At the end, we're going to discuss these cases, and hopefully they will make sense to you. So the first thing is defining what is latent TB infection compared to TB disease. So LTBI is defined as the presence of Mycobacterium tuberculosis organisms without any signs and symptoms or radiographic or bacteriologic evidence of TB disease. In other words, in latent TB infection, the bacteria has already entered the body of the person who has it, And the immune system of that person has created a wall, if you will, a granuloma surrounding this bacteria. And this gives this bacteria, they're still alive, but they're at a low rate multiplication and contained within the granuloma. So there is no clinical manifestations, no symptoms, and the x-rays are normal, and there's no bacteriological evidence of the disease. So we call this a state of latency. This state, when the bacteria is contained in the granuloma and not able to produce any symptoms, can last from a few weeks to many, many years. What defines when a person changes from the state of latency to TB disease is mostly the ability of the immune system to control the infection or not control it any longer. So the best test to diagnose for LTBI is really a proxy test, because we are not actually detecting the mycobacteria, but we are identifying an adaptive immune response by interferon gamma release assays or the tuberculin skin test. So briefly, latent TB infection. In latent TB infection, what you observe is a positive IGRA or TST, a normal chest X-ray, no symptoms or physical findings, and if the respiratory specimens are sent, they are smear and culture negative. Compared to pulmonary TB disease, in which IGRA or TST is usually positive, but not always, the chest X-ray is usually abnormal. There are symptoms that could include chronic cough, fever, hemoptysis, night sweats, weight loss, fatigue, decreased appetite. And if there are cultures done, which they're usually sent, they are positive. They could be positive by culture or smear. So as I said before, the factors that affect when a person goes from latent TB infection to TB disease depends basically on two categories. Those who have an increased likelihood of exposure to persons with TB disease, and those with clinical conditions that increase their risk of progressing from LTBI to TB disease, which are mostly conditions that suppress the immune system. So when we look at the likelihood of TB exposures, the most important category in group of people is the close contacts to a person that has been diagnosed with TB disease infections. Also included in this category are residents or employees of high-risk congregate settings. So that includes correctional facilities, homeless shelters, healthcare facilities. The recent immigrants from regions of the world where TB is endemic, and especially if that their arrival is within the previous 5 years. So the risk from going from LTBI to TB disease declines exponentially over the first few years. The risk is highest in the first 2 years of infection, and it is estimated it is about 5%. So that means 1 in 5 person years. After the first 2 years of the infection, that risk decreases to 1 in 1,000 person years. And this is in the general population without any immunodeficiencies. So the lifetime risk for a person is calculated to be 10 to 15%. However, that risk increases substantially to anywhere from 5 to 15% annually in the immunocompromised. Now, when we talk about the conditions or persons that are at higher risk for developing TB disease once they have LTBI, of course, we talk first about the children because we're talking about pediatric patients in this webinar. So children less than 5 years of age are considered to have within the pediatric population the highest risk. We also see an increased risk in teenagers, and this has been thought to be associated with the changes of puberty. So in between the less than 5 years and the teenagers, there is a period of time during primary school where kids don't get a lot of TB, and even if they get TB disease, it's usually mild. The highest risk is really people that are infected with HIV, especially if they are not on treatment for their HIV and they're severely immunocompromised. People that have a history of prior TB that was untreated or not adequately treated, and they have fibrotic lesions on chest X-ray. People that are malnourished, so their body weight is less than 10% of the ideal. Those who are receiving TNF-alpha antagonists for treatment of rheumatoid arthritis or inflammatory bowel disease, injection drug users, those who have certain medical conditions such as chronic renal failure, solid organ transplants, diabetes, and others. So before going into the actual test for LTBI infection, it's important to know that the current CDC guidelines call for what we call targeted testing. And that means that the recommendation is to only test for TB those people that have risk factors, or if they have signs or symptoms of TB disease. Before, many years ago, there used to be in pediatrics the rule for testing kids universally every year during their child care visits. However, that has changed, and it's only required for kids that have risk factors. So in accordance to that, the American Academy of Pediatrics, in the Red Book, they recommend the following for kids to be tested with IGRAS or TST. So they say the children who need immediate IGRA or TST would be those that are in close contact to confirmed or suspected cases, right? So the contact investigation. Children that have radiographic or clinical findings suggesting of TB disease. Children that immigrate from countries with endemic infection, and that includes most of the world except for some of the countries in Europe and North America, and that includes international adoptees. And children with history of significant travel to countries with endemic infection who have substantial contact with the residential population of that place. It's important to know that to decide on what test to do, we'll go over that in more detail, but the cutoff age for that would be 3 to 4 months of age for TST and 2 years for IGRAS. And another point is that for the children that immigrate from other countries or have significant travel to countries where TB is endemic, if they come to you and they are asymptomatic and they just recently came, it's better to wait about 8 to 10 weeks from the time they came back or the time they immigrated to do the test. I know this is difficult for immigrants because they usually get tested as soon as they come into the country, But if you think about the incubation period, that's the time that it takes from a person that is infected with TB to actually show a positive test, either TST or IGRA, is 8 to 10 weeks. So if you think about it, if you test people that recently immigrated and they test negative, they could be in the incubation period and you're not really screening them in the right time. So if you have time and it's a patient that you are going to continue to follow, the recommendation is to try to wait up to 10 weeks after their return or they're entering the country to do the test. Children who need annual IGRA or TST, it's really only the children that are infected with HIV. And we do that in my clinic. And then children that are at increased risk of progression from LTBI to TB disease based on their condition deserve a special category. So these are the kids that have those conditions that we talked about, the diabetes, chronic renal failure, malnutrition, immunodeficiencies, patients that receive tumor necrosis factor antagonists. So without an exposure to TB, they're not really at increased risk for developing TB disease. What is important is that if they get infected or if they get exposed to somebody with TB, they have a higher risk from developing TB disease and not staying in that latent phase. So what is important on these kids is to get an initial good history about all of the potential exposures to TB before you decide if they need to be tested or not. If the histories are consistent with a potential exposure, then of course immediately you send an IGRA or a TST. This is according to the Red Book. And if the persons, those patients are seen by you before they actually are going to start an immunosuppressive therapy, including a prolonged course of steroids or organ transplantation, or they're going to be started on TNF-alpha antagonists or blockers or other immunosuppressive therapy, it's better to test them, even if they don't have any exposure. It's better to test them before they start those therapies, because you have a better interpretation of the test based on their immune competency before they are started on immunosuppressive therapy, if that makes sense. Now, the Red Book has published a questionnaire that has been validated in states that have a high population of immigrants or international visitors, to try to decide when a child needs to be tested for LTBI. And these are the major questions. Has a family member or contact had TB disease? Has a family member or contact has a positive TST result? Was your child born in a high-risk country? Has your child traveled to the high-risk country? And how much contact did your child have with the resident population in that country? If the answer is no to all of those questions, then you don't need to do a test, TST or IGRA. If the answer is yes to one of those questions, it's indicated to go ahead and do the test. Now, let's talk about the tests that are available right now to detect MTB infection. Those are interferon gamma release assays and the MAN2 tuberculin skin test, TST or PPD. These tests are, as I said before, are really testing the adaptive immune response to MTB, not the actual bacteria. They do not exclude TB infection, and they do not distinguish LTBI from TB disease. So that is important to know. A negative test in a patient that has symptoms of TB does not exclude it. And you can use the test to distinguish who has LTBI and who has TB disease. The only thing that the test is going to tell you is that that person has been infected with Mycobacterium tuberculosis. So the decisions about the medical and public health management of people, once you test for TB infection, either using IGRA or TST, need to consider all of those things and not deciding on the management based on the TST or IRA alone. So let's talk about the tuberculum skin test. This is a test that has been known for and used for over 100 years. And so basically you take the protein derivative and inject it intradermally in the anterior aspect of the forearm. And then it's important to form a little well there. One thing that I have to say before we go into the results is that ideally the test needs to be placed by somebody that has experience or has been trained in how to administer the test, because it looks simple, but believe me, in children it's not that easy to do. You just have to see those kids trying to stay still to get those tests done, and you see how difficult it is. So it's important to have a good person and a person to hold the kid before trying to administer this test. And then 48 to 72 hours later, you interpret the test. So basically it's 2 visits, one for administering the test and the second time to interpret the test. 48 to 72 hours later, you read the induration around the site of the injection, not the redness, but the induration. And it's important to measure it and read it in millimeters of induration. Based on that, there are 3 cutoffs for calling a positive PPD. And those depend on the size of the induration, but also depends on the risk factors of the person. So we use 5 or more as the cutoff, consider it positive for recent contacts of people with TB infection, children that have X-rays or clinical conditions that are suggestive of TB disease, for children living with HIV, children with organ transplants, and those that are receiving other immunosuppressive therapy, such as the TNF-alpha antagonists. Then we go to the next category, which is 10 millimeters. So 10 or more is considered positive in children younger than 4 years of age, regardless of the risk factors, just based on the age. Children that are born in high prevalence regions of the world or who have traveled there and have had contacts with resident populations, and the children that have the medical conditions that increase their risk for developing TB disease. Also, we include in this category the children and infants that are frequently exposed to adults that are on the high-risk categories. Then we go to 15 millimeters of induration, and that is considered positive for anybody, even without any risk factors. So anybody that has more than 15 millimeters, either 15 or more, is considered positive for TST. So there are multiple things that can cause a false positive reaction on the TST. Those include infections with non-tuberculous mycobacteria, BCG vaccination, administration of an incorrect antigen. And this happens because there are other components that people do to test for allergy, and sometimes they have candida antigens or tetanus antigens. So if somebody uses the wrong antigen, then obviously it's a wrong answer. And then, of course, like I mentioned, incorrect measuring or incorrect interpretation of the TST result. Factors that can cause a false negative reaction includes allergy, and that can happen when a person has severe TB disease. We recently had a kid with miliary TB disease that was allergic, so his PPD was negative. Recent TB infection, so if they are in that incubation period that I mentioned, 8 to 10 weeks between the infection and the actual immune response, they could have a false negative response. Kids that are younger than 4 months of age, and if they have received recently live virus vaccinations like measles, smallpox, some people include chickenpox also in there. incorrect method of giving the test, incorrect measuring or interpretation of the test. So you can see there's many reasons why this test can be false positive or false negative. There's also another thing that happens with TB and PPD. Some people that have LTBI for a long period of time can test negative on the TST because the response of the immune system wanes over time. So if they get infected, let's say when they were children and they come here when they're adults, um, they can have the first test, the PPD can be negative. However, the TST, so putting the test actually boosts the immune response, basically reminds the immune system that they have seen this bacteria. And the second test after the PPD, so a second PPD, could actually be positive because the reaction was boosted by the TST administration. And so many times people misinterpret this result as a new infection when it really is a boosted phenomenon from a very old infection. And it's and you can see boosting with when you put PPDs on people that have been vaccinated with BCG. The problem is that once you boost the response and you get a positive, it's hard to distinguish if it's a new infection or is a boosted response. So in summary, limitations of the TST include subjective interpretation, difficult to maintain the proficiency in administration, reading, and interpretation. So obviously, what I tell people when I give lectures about TB is that it's very easy to say theoretically how to read and interpret this test. However, if you have not actually done it, if you have not actually read a positive TST, it is you don't realize how difficult it is. The other day I was given a grand rounds and I asked in the audience who had ever read a positive PPD, and there were 2 people in a room of like 200 people that have ever seen a positive PPD and read it. So if you've never done it, you lose the proficiency on how to do it. So it's hard to keep that proficiency because we don't see that much TB in the United States. So that's a big problem. Of course, it requires 2 visits. One is to administer the test, one to read it. It cross-reacts with BCG vaccination and not tuberculous mycobacteria. There is a boosting phenomenon. And despite the many years of using it, there is not a standard way to record or retrieve the results. I don't know if you have ever actually gone to a medical record and tried to find out where in the medical record they have the result of the PPD. It's a nightmare. It depends on the system that you use, and even within the same system in the hospital. So people put it on their nursing notes, and people put it on the physician's notes, and put it on the other note. You just have to look and look and look to find it. It's not easy. It's crazy, but it's not easy. Okay, so then move along. We'll go to the interferon gamma release assays, and these are ex vivo whole blood tests that I use to detect the immune response to MTB, just like TST does, but this is ex vivo. So there are 2 tests that are currently approved and in use in the United States. Those are the T-spot TB test, which, by the way, is the only test that has no FDA limitation for use in children over 2 years of age. And then the quantiferon TB Gold test. So how does the IGRA work? The principle is that the immune response to the infections with MTB is mediated mainly through T cell activation. So as part of the response, the T cells, CD4 and CD8, are sensitized to the bacteria antigens. And so the response to the sensitization is that they start producing a cytokine called interferon gamma. And they start releasing that when they are stimulated by the antigens. So the IGRAS, the interferon gamma release assay, directly or indirectly measure the amount or interferon gamma that is released by the blood cells in response to the antigens. These tests entail mixing blood samples with antigen from NTB. The test, both of them use the proteins ESAT6 and CFP10 are the antigens of TB that it uses, and then it uses controls, positive control and negative control. See, the amount of the interferon released in response to MTB antigen is compared to the amount released by the other antigens, the negative control and the positive controls. So this diagram kind of explains how the T-spot TB test works. So it uses the ELISpot methodology to enumerate the number of T cells that are actually releasing interferon gamma. Just to go over these very quickly, let's see if I can put the pointer. So the blood is collected into a single tube. The next step is very important. So the sample is taken and they wash the cells, and then immediately after washing the cells, they standardize by counting the cells. So the step of washing the cells is important because there are substances in the whole blood that can interfere with the reaction, such as steroids and other substances that can actually interfere with the response. So by washing the cells, we are trying to minimize that interference. And then the other thing that is important in this is that there is standardization of the number of cells. So they count the cells and they put 250,000 cells in each well. So this actually corrects for patients that have low T cell counts in their blood. Then those cells are incubated with antigens, the TB antigens, and they're washed again, and then they are submitted to several reactions that basically capture the interferon gamma that is in the membranes around the cells that produce it. So the result is that you see spots, and those spots identify the cells that are releasing the interferon gamma. The quantiferon TB Gold Plus test is a fourth-generation quantiferon test, so it's more recently released, and they use the enzyme-leak immunoassay methodology. And they do that, they measure the actual amount or interferon gamma that is released. The current test, which is the Plus, uses 4 tubes. One tube has the mitogen, so the positive control. The other one has the background we call nil, is the background test. And then the other 2 tubes contain the antigens with CD4 cells and CD8. And the test actually measures the amount of interferon that is released after the incubation with the person's blood. So it's important that before you're going to administer the test, you arrange for the time where it's going to be done, because with all blood tests that are done that we need live cells, the samples need to be processed in a timely manner, because that can affect the results. So it's important to do it at a time where you can process the samples, retrieve the samples in a timely manner. And then you follow basically the instructions in the test manufacturer's package insert. You have to do a follow-up test just to go ahead and discuss results and decide if they need treatment or not. In here, what I just want to highlight is that for the T-spot TB test, there are different quantities of blood that you need to put in the tube depending on the age. So for example, for adults and children older than 10 years of age, it requires 6 mLs of blood. For children that are between 2 and 10 years of age, it requires 4 mLs. And for children up to 2 years of age, it only requires 2 mLs of blood. For the quantiferon plus, you can either put the blood directly into the 4 tubes, or it can be a single collection in 1 tube. But the minimum that is required, regardless of the age, is 4 to 5 mLs. So in summary, a comparison here between the T-spot TB test and quantiferon plus. I'm not going to go over the whole table, but the things that I want to just highlight on this slide is that the T-spot TB test uses cells, and it standardized the test in a way that the same number of cells are put in the wells. So that's important. They have a category. So in the results, they have a category that is called borderline. So it's positive, negative, borderline, or invalid. This is an important thing to highlight, because what they do is instead of trying to just divide the responses into just two, positive or negative, they account for a number of spots that they count that are not, they are like almost borderline positive or borderline negative, and that allows for more accuracy of the test. So for example, if you have only a test that it's only, let's say, 5 is the cutoff. This is not the case in this, but an example, if you say that 5 is the cutoff, less than 5 is positive, more than 5 is negative, then when you have 5 exactly, you could be very borderline between negative and positive. So by having a borderline category, they avoid that. And whenever a test is read as borderline, it is recommended to repeat the test instead of trying to guess if that was a borderline positive or a borderline negative. And I think that's really an important category. The quantiferon test does not have that. It's positive, negative, or indeterminate. The other important thing in this is that the T-spot TB test is the only one that has no FDA limitation for the use in children 2 or older, and also is not impacted by the immunosuppressive status, because it kind of like equalizes that by counting the cells. The quantiferon TB plus test has in their package insert some limitations, with not that many studies done in the immunosuppressed or in kids younger than 17 years of age. In summary, the IGRS advantages are that it requires a single visit to conduct the test. It's a controlled laboratory test, so it takes away the subjective interpretation of the test. The results are usually available within 24 hours. There are no booster responses to subsequent tests. It is definitely more specific than TST because it doesn't cross-react with BCG or non-tuberculous mycobacteria. And the use of IGRA really may increase the acceptance for LTBI treatment because it takes away the issue about the BCG vaccination. Some of the disadvantages that it has is that there's limited data on the use in children less than 2, although there are some data and more data coming out on uses even in younger populations than that. Also limited data on recently exposed people to TB and serial testing. Just like TST, the IGRAs do not predict who will progress to TB disease in the future. So comparing quickly IGRAs and TSTs, as I said, there is in IGRA, there are specific antigens for TB versus in TST is a single antigen that actually cross-reacts, that is common in non-tuberculous mycobacteria and BCG vaccination. There is no boosting phenomenon in IGRA. There is one patient visit. You have a minimal inter-reader variability, which you have a huge of that in TST. And it's not affected by BCG or most non-tuberculous mycobacteria. So when you're going to select the test, let's say you do your questionnaires, you do your interrogation and decide that somebody needs to be tested for TB. So which test do you decide? These recommendations here are directly from the CDC guidelines for LTBI testing. So IGRAs are the preferred method of testing for groups that have poor rates of returning. So remember, in TST, they have to return the second time. And one of the major problems is that people don't return. So once they miss the window for reading the test, you can't really interpret the result. And also, it's the preferred test for persons that have been vaccinated with BCG. TST is the preferred method for children under the age of 2, and that's pretty much the only time where TST is preferred by CDC guidelines. And even then, there are actually more data that supports the use in either kids that are younger than 2. So in the other categories, pretty much the CDC guidelines say that either IGRA or test can be used. And other things that it's important to remember that is a negative result from either an IGRA or a TST should be considered unreliable in kids less than 3 months of age. The use of the 2 tests is not recommended for the most part. So a lot of people think of doing both tests, and that's just really a waste of time and money, and then confusion and interpretation. There are some times where we do it, and that is, for example, when that we do both tests, and that is, for example, when the initial test is negative, but you're really worried about the person having TB because of the high risk of infection or symptoms that are consistent with TB disease, and you want another test to try to see if you can get a positive. Also, when the initial test is positive, but there is the question that if it is a true positive or a false positive, try to convince the person that is going to be treated that they need to be treated, or if it's unclear or indeterminate. So there's, I want to share with you a little bit on the data on this study that was published in 2018. It's a study conducted by the CDC, and it's a prospective cohort, including populations at high risk for TB in the United States. Important things to remember is that what they did is they tested people that are at risk for TB with the 3 tests, T-spot, quantiferin, and TST. And then they also were able to estimate the true prevalence of LTBI using a statistical method called latent class analysis. What I like about this test is that this study and this publication is that they actually have data on 516 children less than 5. And this is really the only study that I know of that has that specific data of the 3 tests in populations this young. They also had a bunch of kids older than 5, 8,000. So in the group of children less than 5 years of age, the estimated prevalence of LTBI was 4%. And they calculated the positive predictive value of the 3 tests. In the children more than 5, the prevalence was a little bit higher, and that improved the positive predictive value of the other tests. But it's still, if you see here, the positive predictive value of TST in children less than 5 is only 10%, and it's up to 60% in children more than 5, but that is still pretty low compared to 99% on T-spot TB on more than 5, and 70, almost 80% on children less than 5. So what does that mean in regards to your clinical practice? This is really important. That means that if you put a TST on foreign-born children and it tests positive, 90% of those positives are false. So those kids have a positive TST and do not have LTBI. And that's really important. In children older than 5, that is true 40% of the times. Children that are foreign-born that have a positive TST do not have LTBI. So that's a high number of patients that are tested positive, that it's basically considered a false positive. But if we don't know the results of the IRA, we tend to treat them as true positives, and that means that they are treated for LTBI that requires a lot of follow-ups, medications, etc., when in these cases is unnecessary. A word on the immunocompromised. So there was a review article published. Now it's a little bit older, but it's really a good comparison. And they basically were looking at the performance of these tests in the immunocompromised population and concluded that the accuracy of the test really depends on the type of immune compromising condition that the patients have. So, for example, IGRA show a very definite superiority over TST in HIV-infected people, end-stage renal disease, solid organ and bone marrow transplant patients. And in these, the difference was not as great, but it was better than TST. Many times in these cases of solid organ transplant and transplant patients, people feel more comfortable doing both tests, the TST and the IGRS. No difference was noticed in this review in patients receiving some of the immunosuppressants therapy. And basically, like in everything else, it's important before categorizing these tests as positive or not to look at the clinical situations and the epidemiological risk factors of the patients before interpreting these results. Some of cautions on interpreting IGRAs. As I said, if you have a positive IGRA in a patient, you should consider that child infected with TB. But a negative IGRA does not rule out infection. So positive, definitely yes. A negative doesn't rule it out. Indeterminate results or invalid results are like that for different reasons that could be with the characteristic of the patient or the performance of the test or the way it was handled, the sample. But you should not rely on that. When you get results that are indeterminate or invalid, basically it's not interpretable and the test needs to be repeated, either the same test or a different test. But you can really try to interpret that. It should not be used to make any clinical decisions, basically. Okay, now we're going to end up this whole topic with the workup for children with suspected TB. So as with everything, the diagnosis of these illnesses, history and physical exam are important. But in TB, 90% of the times the diagnosis or it's in the history and the physical exam. But of course, then you have your other tests that can help, such as the T-spot TB or TST, chest x-rays, and then cultures. History is really important. In this study that was published it's a study done also by the CDC, was published in 2012. It's important because it's the first time that they look at the data on the parent or legal guardian, country of origin, and the history of international travel. So in the previous studies that have not been really entering into the analysis. So they found 2,600 cases of TB, and 1/3 of those cases were symptomatic. So that means that 2/3 did not have any symptoms, but they had disease. And that's important to remember. 31% of this population was foreign born, and 52 of those were actually teenagers that had lived in the country for more than 3 years. Interestingly, among the US-born patients, 66% of those had at least one foreign-born parent, and 30% of them had lived outside of the United States for more than 2 months. So, really, if you put all that together, that means that of the 2,600 cases that they had in that period of time, 75% of them had an international connection. So either foreign-born parents, or residents outside of the United States, which again highlights the importance of asking those questions when you're actually asking for risk factors for TB. So that brings me to this slide, is just to highlight the importance of doing an appropriate screening test. So as I told you in the previous test, 1/3 of the patients were symptomatic. So that means the other 2/3 were catch because of active investigation. So contact investigation or screening of high risk groups. And then the passive is when you have symptomatic children and they're diagnosed because they are symptomatic. So the goal is to try to detect these cases actively before those kids are sick. So many of those kids that are detected by contact investigation or screening of high risk groups have no symptoms, or have very mild symptoms. They could have just a mild cough, and they could be missed if you're waiting for the typical symptoms of TB. So it just really highlights the importance of a good contact investigation and screening if they have high risk. Now, of course, any patient that has symptoms of TB disease should be evaluated immediately, regardless of what the TST or IGRA results are, because these kids can get sick very quickly and they can get severe disease, especially the younger kids. And this is an important slide because this is something that is frequently missed. When you are doing a contact investigation, or if you have a patient that is less than 5 years of age and has been in contact with somebody with contagious TB, we manage them like immunosuppressed patients and very, very rigid evaluation. So they need to have an IGRA or TST test, a chest x-ray, regardless of the IGRA result, and they should have a review of systems and exam. And then if all of that is negative, they need to be started on what we call window prophylaxis or primary prophylaxis. So everything is negative, the T-spot, the chest x-ray, the exam, then they get started on INH, wait 8 to 10 weeks. Remember that incubation period to get the test back, to convert from negative to positive, and then repeat the test. If the repeat test is negative, you can stop the INH. If the repeat test is positive and they continue to be asymptomatic, then you treat them as LTBI. So these kids are treated as immunosuppressed, and they have because they have a high risk of developing very severe TB disease. Okay, so then you review the symptoms, do the exam, and then review the chest x-ray very carefully. Whenever you send the chest x-ray, either because they're high risk, because of symptoms, or because they have a positive IGRA, you need to review the x-rays very carefully. It sounds easy, but it's not that. So if everything is normal, then their diagnosis is LTBI infection. If anything is abnormal, obviously they need to consider additional work for TB disease. So I want to share with you some of the x-rays just to highlight the difficulty of some of these x-rays. So the most common finding in primary to pulmonary TB in kids is hilar lymphadenopathy. So this, in this case, well, it has the arrow here, but you can see this shadow here is a hilar lymphadenopathy. This is the same over here, but on the other side, this over here is a hilar lymphadenopathy. Sometimes you see images that look similar to that in younger kids, that it's the thymus that hasn't decreased in size yet, and sometimes it's kind of hard to distinguish thymus from hilar lymphadenopathy. You need a pediatric radiologist to actually read, and not only pediatric radiologist, but somebody that is has experience reading TB in children. Sometimes you find these infiltrates that do not respond to antibiotics, that are treated like pneumonias, and it doesn't open up. In this case, this kid has a hilar adenopathy here that you can't see, but it's so big that it's actually compressing the right main bronchus, and it's causing a collapse of the right upper lung. So this is not really an infiltrate. This is a huge atelectasis, chronic atelectasis, because of the compression of the hilar lymph node. So those are tricky sometimes. This is more obvious. So this is, especially if this appearance of this X-ray changes quickly from a normal to this, You have a nodular reticular pattern all over. It's basically consistent with miliary TB. You can also have large pleural effusions in kids with TB that we've seen also. And then we also see the upper lobe cavitations, but we don't see these often in young kids, but we see it in adolescents. This is a result of reactivation of a latent TB disease. Okay, so usually when you're in kids, when you have a case that is infectious that the kid is exposed to, you can kind of assume that the same bug that the source case has is what the kid has. And so many times you don't actually have to do a test, but you just have to be careful with making sure that you're connecting the patient and the source case correctly. The American Academy of Pediatrics suggests that you do cultures in young children when you don't have a source case, when there is any suspicion of multi-drug resistant TB, when the child is immunocompromised, and in all the cases of extrapulmonary TB. So once you decide to do tests, which is the best test to do, this is obviously hard in kids. For example, in young kids, we use gastric aspirates because it's very hard to obtain sputum from them. But you can actually, and this has been shown in several publications and studies, that kids usually by 5 to 7 years of age or older, you can actually do induced sputums like you do in adults. So if they don't have a productive cough, you simulate their cough with hypertonic saline and induce them to cough and then collect the sample. This has better accuracy than gastric aspirates. If the children have or adolescents have a productive cough, you don't have to induce the sputum. You can just collect the sputum samples. And then, of course, you collect any sample that you have available, pleural fluids, CSF, urine, other body fluids, biopsy specimens, all of those are cultured. And if you're going to do the gastric aspirates or the induced sputums, it's important to collect 3 samples. We usually do 3 separate days. It's important to remember that even when you do cultures, many times the cultures are negative. So the yield of these cultures in kids, it's relatively low compared to adults. So most of the cases in TB are not confirmed bacteriologically. They're what we call clinical cases. So they have a history of a recent contact to an active case. They have a positive T-spot TB test or IGRA or TST, abnormal chest X-ray on exam, and no bacteriological confirmation. But because of the fact that we don't have the confirmation bacteriologically, it's very important that we use an accurate test when we're going to test for LTB, for TB infection. So after that, we're just going to go back to our cases and going to try to answer the questions. So the first case, as you remember, is a 2-year-old Hispanic female that came from Guatemala, had BCG vaccination, potential exposure to a grandmother in Guatemala that was recently diagnosed with TB. She's asymptomatic, normal exam. So what do you do next? So the questions are, should you do IGRA or should you do TST? Or should you do both? In this case, the answer for sure is IGRA. Most likely T-spot TB because this kid is only 2 years of age. You wouldn't do PPD or TST because this kid is vaccinated with BCG, so you're going to get a false positive reaction there. Would you do a chest X-ray on this kid? Remember what I said? She's young, she has an exposure, so you should do an X-ray regardless of the results of the TST or IGRA. You should do IGRA and chest X-ray. Obtain samples. Well, only obtain samples if the chest X-ray is consistent with TB and if the grandmother you don't have the isolate from the grandmother. So if the grandmother was in Guatemala and you don't have access to that isolate, you should try to collect the samples on this kid. And what would be the best sample? In this case, would be gastric aspirates. Next case is the 12-year-old Chinese male that also has had a BCG, came to the United States, A PPD was placed and it was 30 millimeters. His chest X-ray is normal. He doesn't have any symptoms or signs of disease. And in further questioning, he doesn't have any history of any known TB contacts. They offered him to be treated for LTBI. However, the family refused because they believe that the TST result is due to the BCG vaccination. So what do you do next? The first thing is to send an IGRA, because that can distinguish the reaction between BCG and true TB infection. If the IGRA is positive, then definitely encourage him to be treated for LTBI. But now you have a tool to convince the family that the result is not from the vaccine, because the IGRA does not cross-react with the vaccine. And if negative, no treatment is necessary. So you have saved this kid from whatever. You go from 4 months to 9 months of treatment that was unnecessary because you did the wrong test. That was a false positive. So it's important to clarify that in some of these patients. The third and last case is the 17-year-old female who was diagnosed with Crohn's, had corticosteroid therapy, but did not respond. The GI doctor wanted her to start on Humira, and then we're deciding what to do. She has no symptoms of TB disease, no known TB contacts, but does have a little bit of a risk history there, as she volunteered in a food bank for homeless. So that is considered a high-risk population. So basically, what do you do next? Does she need to be tested for latent TB infection or LTBI? Yes, of course she needs to be tested for that, for two reasons: potential exposure, and she's going to be started on a very immunosuppressive therapy that is going to put her at higher risk of developing TB disease if she actually got the infection. So she needs to be tested before started on Humira. So if you, since you're going to do the test, which test would you do? Definitely you would do an IGRA, not a TST, and most likely you would do, or I would do, a T-spot TB test because of the previous history of corticosteroids. I feel that it has an advantage over quantiferon in immunocompromised populations. Some people would do both because they want to be absolutely sure that you are not missing TB in a kid that you're going to immunosuppress. So that's a valid response to do both. And then the other question is, should you even test her, or should you just go ahead and treat her for LTBI? Because the question is, can you trust the test on a kid that has been on steroids? So this depends really on the level of immunosuppression. So for example, our HIV kids that are on therapy, that have a healthy immune system, good CD4 counts, we trust the test. And we have a kid that is HIV positive, that is not on treatment and has a very low CD4 count. We wouldn't, if he has been exposed to somebody with TB, we wouldn't even try to not treat him. We would go ahead and treat him because the chances are too high. So in these cases, you have to just evaluate how severe the immunosuppression is and how high was the risk of the exposure before deciding if you go ahead and treating them regardless of what the test results are. So in summary, IGRAs have many advantages compared to TST. For one thing, it's increased specificity and it doesn't compromise sensitivity. No interreader variability, which is a big problem in TST. The T-spot TB test can be used in children more than 2 years of age. Some experts will go down to 1. That includes myself. I do work with the Southeastern National TB Center and get to advise in a lot of cases of TB in young children, and we do use T-spot TB on kids all the way down to 1 year of age, with very good success in getting good results. Remember that for sure, if the kid is BCG vaccinated, you should definitely do T-spot TB or an IGRA, not TST, because the TST results are very, very non-specific in these circumstances. And remember that nor IGRA or TST can distinguish LTBI from TB disease. So in these cases, you have to use your clinical judgment and not depend on the test alone. These are a list of references for this topic. Thank you so much. Now we will discuss some of the most frequent questions that we get on this topic. So if you have other questions that are not covered in this session, you can put the question in the web page, I think, right? The web page. Okay, so let me see. Let me go ahead and read the questions. So one of the questions is, why is sensitivity and specificity of importance when testing for LTBI in children? So sensitivity is very important because especially young children less than 5 years of age have a high risk of developing more severe forms of TB. So TB meningitis, miliary TB. So you want a test that is going to catch most of the patients that are infected. So that's the sensitivity. Specificity is important because it will just really tell you if a test is truly positive or take away the cross reactions with other tests. And this is important because if you're going to treat these kids, you want to make sure that really they deserve the treatment and not put them on treatment just because. In one study published by Dr. Ahmed and colleagues in pediatrics just recently, they show that changing from TST to an IGRA test like T-spot could reduce unnecessary tests and treatments for up to 2/3 of non-US born children. Why is this finding important? Again, it's similar to the data that I just showed you in that study done by the CDC, in which if you use, for example, TST, 90% of the positives are false positives in kids younger than 5 years of age that are immigrants. And in this particular study, they follow the kids on that study prospectively to see which of them would develop TB. And none of the kids that had a positive PPD and negative IGRA, and they were not treated because the IGRA was negative, none of them developed TB disease. So that is highlights the importance of that. So unnecessary treatment and unnecessary waste of healthcare resources. You can avoid that by using IGRAs. Second question. Why is the small amount of blood volume required to run the T-spot TB test would benefit the patient and the clinician? This is especially important in pediatric patients, especially the young kids, because it's not that easy to get a large amount of blood on them. And of course, the amount of blood is proportional to their size. Some of these kids are tested when they for TB when they're tested for other things. So they actually have to add the amount of blood required for the TB test to other tests that are going to be sent. So using a smaller amount of blood helps in that situation. Basically, people will lean more towards using less blood than a test that requires less blood than a test that requires more blood from small kids. The third question is, why would you consider that washing and standardization of cell counts is important to bear in mind when screening for LTBI in children? Well, it's important because the washing, for example, is important because you really get rid of substances that are in the plasma that can really affect the results, interact, and cause difficulties to interpret the reaction. So I think it minimizes the indeterminate results. And the standardization is important because it really cuts down on the issue of patients that are immunosuppressed that have lower cell counts, white blood cell counts. And this is especially important in young kids because obviously they have less white blood cell counts that are really ready to secrete interferon gamma. So if you standardize it by counting the cells and having a uniform number of cells per wells, it eliminates that issue. So I think that's in my mind, is one of the biggest advantages of T-spot TB test. As a matter of fact, in my personal experience, it's the test that I preferred. It's the test that we use in our HIV-infected kids, and also the tests that we use in younger kids at the health department where I work at the TB clinic, because we have much less issues of indeterminate results or invalid results. One more question. So it says, can you walk us through the latest recommendations and guidelines of latent TB in screening in the pediatric population? Yeah, so the guidelines are long, but I could summarize it in two things important to remember. One, we recommend using targeted testing for TB. That means that you should only test children that have risk factors, or obviously if they are symptomatic and have symptoms consistent with TB disease, yes. But if for screening, only do the test on kids that have high risk factors. So that means contacts of TB, with TB patients, contacts with high-risk populations, traveling or immigrating from countries where TB is endemic. Those are all high-risk factors for which you should be testing the kids, but only test the kids that have risk factors, not universal testing. One thing to remember. And second, if you're going to decide to test, then I would strongly consider IGRAs in all kids older than 2 years of age. I personally go down to 1 year of age, and this is something that a lot of people that work with pediatric TB are doing. We're collecting data, so hopefully that data will be out. But right now, as of it is right now, 2 and up is perfectly fine. And the tests that I prefer in those cases are the T-spot TB test, because has less problems with invalid results, and also has no FDA limitation for children older than 2 years of age. TST really, it's only preferred in the cases of kids that are too young to get, where you can't trust the IGRA. So I'm talking about like 3 months to maybe 1 year of age, that age range, that they're young. Maybe in those cases TST is preferred, but everybody, in every other circumstance, IGRA is the preferred test. You can do TST in the other kids that are not BCG vaccinated, but really, if you think of the advantages of IGRA, why do TST? You should do IGRA on pretty much everybody more than 2 that you decide that needs to be tested. I think that's it. So I would like to thank you for your time and participation in this webinar. I appreciate your feedback, and please feel free to send questions, comments, suggestions for future topics. And this concludes the webinar for today. Thank you very much.